Invalo, and I'll be moderating today's session. Before we get started, I just want to take a minute to thank some of our sponsors. We want to thank Alexion, Johnson & Johnson, argenx, and UCB. And I wanted to just let everyone know that today's session will be recorded and available to view on YouTube after the presentation. If you would like, you can select audio captions during this presentation, and you just click on the bottom of the Zoom icon down here and select the language that you prefer. If you have questions, you can put them in the Q&A box, and we'll answer them during the Q&A segment. And now it's my pleasure to hand it over to today's speaker, Dr. Sarah Wright. Welcome.
Thank you. Okay. So good afternoon or good morning, depending on your time zone. It's such an honor and a pleasure to present this today for a subject that I feel very passionately about. I am a clinician in pediatric neuromuscular medicine with a special focus in myasthenia gravis, and I work at Children's National Hospital in Washington, D.C. I don't have any relevant disclosures to this discussion. All of these slides are my own personal research, as well as my personal knowledge and interest, and don't reflect on my organization. And so today, I really want to give us some updates on where juvenile myasthenia gravis has been and where we're going. It has been an exciting time with multiple treatments that are new and more targeted towards the actual disease process that have been approved for adults. And we see those treatments, thankfully, slowly trickling down to children, sometimes not as fast as we would like. So we're going to review current treatment modalities for a short amount of time. And then we're going to really spend time to explore recent treatment advances in clinical trials, and then spend some time to talk about what is a clinical trial, how do you get involved, and what are some questions that you can ask when you and your family are looking at trials. And so we're going to start with a quick overview of juvenile myasthenia gravis. And as we always say when we're in training to become pediatricians, kids are not little adults. So there's some unique features that are different from adult myasthenia gravis. And so we typically say that juvenile or pediatric autoimmune myasthenia gravis is really anywhere from birth to age 18. But of course, 18, you don't become automatically adult. We have some similarities in adolescence to adults, and then in some ways that adolescents are different than adults. And so that kind of spans the early first 2 decades of life. Interestingly, we always think of autoimmune diseases as presenting later on in life, but actually autoimmune myasthenia gravis may present as early as 1 to 2 years of life. And the presentation can be different than adults. It is more common for children who are what we call prepubertal or haven't gone through puberty to present with ocular-only symptoms. So that would be weakness of the eyelids, ptosis, or difficulty moving the eyes. And we know that in adults with myasthenia gravis, there tends to be more females affected than males. But actually in young children, there's an equal amount of males affected as females. When we look after puberty, some of those patients will tend to kind of mirror the adult onset presentation. So they may be more female predominance. They may actually present more likely with kind of generalized myasthenia symptoms, which can be weakness of the arms, the legs, changes in quality of voice, difficulty swallowing, for example, in addition to ocular symptoms. And interestingly, when we look at the overlying cause of autoimmune myasthenia gravis in children, we don't commonly see any kind of growths on the thymus gland. So those are called thymomas, which are very common in older adults in their 60s, for example. But children may have some enlargement of that gland or thymic hyperplasia. And so imaging is still recommended for all children who have generalized symptoms of myasthenia gravis. And we'll talk about how that's a treatment approach in a little bit. As for the clinical course, the good news is that children actually do seem to have some higher rates of spontaneous remission than adults. So that can range from anywhere from 15 to 35%. However, we know that these findings can based on some epigenetic factors likely and based on ethnicity. Unfortunately, at this time, studies are still very limited, and most of those have been performed out of Asia or Europe and a few in North America as well. But it seems to suggest that patients of African descent may actually be more likely to present with generalized symptoms even in pre-puberty and have a more protracted or difficult course throughout their lifetime for their disease. And it seems that children of Asian descent may have substantially higher incidence of just ocular-only presentations, or just ptosis or eye weakness. And some of this may be related to genetics, and we really need more studies to understand why. And so although myasthenia gravis is a really rare disease, it's recognized by the Rare Disease Consortium. It is actually, fairly common in something that I see in children. And actually, if you take all of the cases of myasthenia gravis in Europe as well as North America, about 10 to 20% of those cases are going to be pediatric. So this is really an area of need for more knowledge and information. The way we diagnose pediatric myasthenia gravis is the same as adults. So based on a clinical suspicion, based on symptoms of ocular symptoms or generalized weakness or changes in voice or swallowing, we will test for antibodies. The most common in kids are still going to be acetylcholine receptor antibodies, although as compared to adults, these actually may be found in less likely or smaller proportions. So adults will have, 80% of them will have acetylcholine receptor antibodies. That range is actually from like 50 to 70% in kids. And then we will also test for what is called MuSK antibodies and sometimes LRP4. Children also, similar to adults with MuSK antibodies, especially postpubertal children, can present more with what we know as bulbar symptoms, so difficulty swallowing, difficulty talking, weight loss. And so if we see that presentation, we have a higher suspicion for MuSK. And LRP4 is very uncommon. Unfortunately, in children, and specifically in ocular-only presentation, they may actually be more likely to be seronegative. Like I said, there's less proportion of children who have acetylcholine receptor positive antibodies. And then if those antibodies are negative, we go on to other testing, and some testing that can be pursued is an EMG or something called a single fiber EMG, which is out of the scope of this discussion today. They can be done in children. It all depends really on the children's age, their tolerance, as well as how experienced the provider is who's conducting the test. And then lastly, similar to starting medications, we can actually trial acetylcholinesterase inhibitors in a controlled setting and examine a child before and after to see if it helped. And that gives us a very strong supportive evidence that this is likely seronegative or antibody negative myasthenia gravis. And so what are the autoimmune mechanisms of myasthenia gravis? This, again, is the same as adults, although we know less about children in the constituency or how much of their immune system is contributing to everything and what parts. And so the autoimmune mechanisms of myasthenia gravis, we know, for example, that our body is producing antibodies, and these antibodies can be directed at those 3 different receptors that we talked about on the previous page. So acetylcholine receptor, which is seen right here, and LRP4, which is a less likely one to be found. Those are what we call IgG1 mediated antibodies. That's the kind of pool of antibodies that are produced. And then antibodies to MuSK, which are a different pool, or IgG4. And how does this lead to damage? Well, specifically in acetylcholine receptor positive myasthenia gravis, those antibodies can block the message from coming through, and that can lead to weakness. Those antibodies also can actually link up these acetylcholine receptors, and then the muscle cells take them down in, and so there's less receptors available even for that message to get through. And then lastly, one of the causes of really kind of fixed or permanent weakness over time is that our immune system responds to these antibodies. And our immune system responds to antibodies by releasing something called complement. And this complement essentially binds together and gets cleaved and actually ends up causing damage to the muscle. And so when we look at the whole system, the whole immune system and how it's affecting this process, it's very complex. But it also is the way that we have found different treatment modalities for myasthenia gravis and juvenile myasthenia gravis. And so I'm not going to get into everything here, but we know that there's a big player in myasthenia gravis called the thymus gland. This is the gland that produces what we call B cells or memory B cells that essentially are producing these antibodies that are circulating in our system. And they can either be short-lived or they can actually be long-lived in the bone marrow. And both of these can be good targets for the treatment of myasthenia gravis in the long term. And like I said, there's this one kind of part on the muscle membrane called complement. And there's now a lot of targeting therapies for complement inhibitors that seem to be very effective, particularly for patients with generalized myasthenia gravis that are acetylcholine receptor positive. And so we're going to go through the current treatment approaches, how they're good, how they're lacking, and that way that will set us up for some of the newer treatment trials that are going on for juvenile myasthenia gravis. And so the current standard of care or standard treatments for juvenile myasthenia gravis have been around for many years. And in sad part, they haven't changed for many years, although hopefully we're coming to an era of new and targeted treatments. And so the first line therapy that we start for all individuals with juvenile myasthenia gravis is an acetylcholinesterase inhibitor. Now, again, this is unfortunately not targeting the underlying immune changes in your body, but it does help a lot with the symptoms. And the way that it helps is that we have acetylcholine being released from the nerve and talking to the muscle, but there's an enzyme here that actually works to break that down. And so by giving an enzyme inhibitor, we actually allow more acetylcholine to be in between this space to send more messages through. It's generally well tolerated. We do start it in lower doses and we base it on weight, and we give it to a child every 4 to 6 hours while awake. This regimen is not fixed. Every child is different. So some children will need it immediately upon awakening. Some will not need it right after a nap, but may need it an hour later. And so you really have to work with a family and a child to see what's the best schedule for them. When we first start it, we don't go above 30 to 60 milligrams per dose. But we can go up higher as need be to a maximum of this kind of 7 milligrams per kilogram of weight per day for children, or 300 milligrams. And the reason we started a little bit lower is from some of the side effects. So because of this mechanism of action, this actually also affects our autonomic nervous system, or these muscarinic receptors, we call them. And some of those side effects can lead to some increased saliva production, which we monitor closely for any child who has severe weakness with their mouth or swallowing. It can lead to some nausea, some sweating, some abdominal cramping and diarrhea, which is the most common and typically will resolve. And very rarely, especially if it was given in too high doses, it would cause a low heart rate. But that's not something that we see when we use this judiciously and start it slowly and treat as per a patient's weight or the max dosing. And so steroids have been used for multiple autoimmune diseases for many, many years. Although they're very effective, they obviously can come with some big significant downsides. And so the way that we use them in juvenile myasthenia gravis can be twofold. One is that we can use them in shorter pulses for some children who are having worsening of their ocular myasthenia gravis. So for example, if they're having a bout of worsening ptosis or eyelid droopiness, or difficulty moving their eyes, particularly if that's causing them to have blurry vision or double vision. And so that's some ways that clinicians will use it in short pulses, and that can be very effective. And for children with generalized myasthenia gravis who are not in the hospital and not having severe symptoms, if they need additional immunotherapy, typically we would recommend starting steroids at a low dose. The reason for that is if you started at a high dose, there actually can be some worsening of the weakness and the symptoms of myasthenia in the first few weeks. And so starting doses are very low, but can be increased based on a child's weight. And although steroids can be effective, it's been shown they can be up to 80% effective in juvenile myasthenia gravis in controlling symptoms. They have a lot of side effects that are hard for a developing brain and developing body. And so some of the things that I see in the short term from steroids can be significant changes in behavior, irritability, hyperactivity. Rarely, particularly if you're on high doses or very sensitive to steroids, you can actually have that turn into hallucinations or psychosis. You can have difficulty with falling asleep. And then in the long term, there's really a lot of monitoring and observation that's required, because they can lead to things such as shorter stature or growth stunting. They can lead to significant weight gain and what we call cushionitis features, or some enlargement of the facial structures, or bloating that looks like bloating there, higher blood pressure. And then, of course, if at high doses, a susceptibility to infections. And I work very closely with our endocrinologist as well for children who have been on steroids for a longer time and or at higher doses, because our glands that normally make steroids naturally in our body can tend to shut down once you're on steroids for some time. And so it takes a while to slow down that kind of decrease of your oral steroids and make sure that those adrenal glands that normally make steroids will recover. And then there's two therapies that are actually very good for when we have worsening of symptoms or myasthenic crisis. So sometimes children, just like adults, can present with very severe weakness, and that can be weight loss, that can be trouble swallowing, that can be really severe difficulty moving their arms or their legs. And of course, throughout their clinical course, they can have worsening of their symptoms that lead to myasthenic crisis. And of course, we are very concerned about the ability for our body to continue supporting our respiration or breathing when the muscles are that weak. And so that's usually a time when a child's in a hospital, and we can do different treatments, both for a myasthenic crisis, but those treatments actually have been used and studied for maintenance therapy. And those two treatments are IVIG and plasma exchange. So IVIG, or intravenous immunoglobulin, comes in many different forms. There's many different brands. Most of them are intravenous, like I mentioned here, although there are some formulations that can be subcutaneous and delivered at different frequencies, which are good for older children or adults. But both of these work in different ways to kind of help decrease circulating antibodies. So with plasma exchange, it's pretty straightforward. It just removes the antibodies from our bloodstream or serum. With IVIG, it's a little less clear about how it actually works, but it seems to neutralize some of those antibodies and may actually decrease the production of some antibodies as well. What I tend to experience and other clinicians have experienced is that IVIG actually is a really great therapy to use for controlling symptoms in juvenile myasthenia gravis. And oftentimes use it before even trying steroids, because it actually is very well tolerated and it has a much more favorable side effect profile. You'll see, though, if you were to look online, that there's not a ton of studies looking at it in juvenile myasthenia gravis in maintenance therapy. But overall, it's given essentially as a loading dose, and then can be given once every 3 to 4 weeks, or in a higher dose, essentially on a span of 4 to 8 weeks. And most people do have some good response to IVIG. And like I said, aside from some mild reactions, we can sometimes see some allergic or infusion reactions, which are manageable. Some children will have some headaches around the time of the infusions. Rarely that can lead to a very severe headache. It's a very well-tolerated treatment, and we have less concern about some side effects that are seen more commonly in adults, because children thankfully have normal functioning kidneys and otherwise do really well. And plasma exchange can also be very effective. There's a very quick response, usually within, like IVIG, usually within a few cycles of the plasma exchange, or 1 to 2 weeks. But it can be very dependent. And actually, because we're removing so much fluid, you need a catheter that goes into your veins. And so it can be very dependent on the size of a child, their ability to tolerate that. And also that catheter itself comes with some risk for infections. So some of the side effects listed there are really related to the changes in the volume that we have during those plasma exchange sessions. But it has been used by many centers who have experience with plasma exchange for maintenance therapy, and can be a very effective treatment, particularly when we try to get myasthenia gravis under control. And so some other therapies that have been used in juvenile myasthenia gravis that are non-steroid dependent. One of those is a medication called rituximab that's been used for many different indications. It is essentially a medication that's given that blocks our B cells. And so essentially it decreases the circulating B cells. We remember those memory B cell pool in our body. And then, of course, in turn, decreases the amount of circulating antibodies. This is actually the first-line treatment for any patient who has a MuSK-positive myasthenia gravis. And the reason for that is because the IgG4-mediated antibodies respond very poorly to things like IVIG, and have been shown in numerous studies in adults and children to respond very nicely to rituximab. But actually, in more recent years, there's been some nice publications on using rituximab as well in other antibody-positive myasthenia gravis, so acetylcholine receptor, as well as even ocular acetylcholine receptor myasthenia gravis. And these studies have shown that it actually may improve outcomes compared to conventional immunosuppressants like corticosteroids, and can have better efficacy at decreasing those doses of steroids or discontinuation of steroids, and decreased rates of myasthenia gravis-related admissions to the hospital. It is a medication that's dosed based on someone's what we call body surface area, so based on their height and their weight. But it's typically a loading dose that's separated by 2 weeks, followed by a maintenance dose if needed based on someone's symptoms or based on, for MuSK, we can sometimes trend their antibody levels as a good marker of disease. And that's typically given once every 3 to 6 months. Although it is a pretty well-tolerated medication, again, we monitor for infusion reactions during the infusion itself. Some patients have reported some kind of fever, chills, and headaches afterwards. The one thing we do really take care of and look for is that it actually can slightly increase the chance of infection. That's very minimal, but in children who are young, we know that they actually have circulating immunoglobulins, and this is the cause for myasthenia gravis, and actually can cause very low immunoglobulin levels, and so we monitor those closely. We also monitor blood counts very closely. And because of the way it works, you actually can't receive live vaccines when you are getting rituximab because you would not mount any immune response because you don't have B cells there to make that immune response to those vaccines. And then one of the last standard treatments for juvenile myasthenia gravis has been a thymectomy. So we talked about that gland. It's a small gland in our chest, very common in children, may decrease in size into young adulthood and adulthood. And in adults, they can actually have a benign growth or benign tumor called a thymoma. That's less common in children, may be seen in some postpubertal children. But any patient, although less common in young kids, can have some increase of that or thymic hyperplasia in the setting of myasthenia gravis. And so it was found many years ago that if you remove the thymus gland, that you actually have some favorable responses. And so you actually have an increased chance of what we call clinically stable remission, so not requiring increased therapies in generalized myasthenia gravis. A very old study now has shown that a thymectomy within 2 years of diagnosis results in a higher rate of remission, and that was primarily done in Caucasian children. Some of these studies is where we get our recommendation to really try to pursue a thymectomy within 2 years, as long as the patient is stable for a surgery. And this thymectomy can be done in one of 2 ways, but most children now will receive what's called a laparoscopic thymectomy, where it's small incisions on the side of the chest wall, as opposed to opening up the whole chest, and the recovery tends to be much better for that. There was a nice paper recently that actually was able to pull all of the patients for juvenile myasthenia gravis who have been reported that's gotten thymectomy. And one of the most remarkable things is really the improved clinical status, the reduced requirement for medical therapy following thymectomy was 77% of the participants. And complete remission, so that is, stable symptoms without any kind of immunomodulating therapies, was seen in 40% of those. So that's actually a very good rate when we talk about the rate of spontaneous remission, or, just spontaneously not having any symptoms, is around 15 to 35% in children. So that's higher. And so the response rate, the only problem is the response rate may take some time. And that's because once you remove the thymus gland, you still need to reduce the circulating antibodies. And many studies have shown that the body's ability to fight off an infection is not decreased from having a thymectomy. However, we do take care in younger children. There's no standard guidelines. In my own clinical experience, I really won't pursue a thymectomy in children less than 5 years of age, because I know that they're still receiving vaccines and they're still trying to mount immune response to common viruses that are in the environment, but that may vary based on center. Okay, so that's kind of the standard of treatments that we have now, or the treatments that we can use. And so now we're going to go into some of the clinical trials and the recent results and how these work. So I'll try not to get too much into the weeds, but we'll talk a little bit about the mechanism and then some of the studies that have actually had some data for juvenile myasthenia gravis, and then some clinical trials that are still recruiting or still in the early stages. So as we talked about for the autoimmune mechanisms for myasthenia gravis, one of the big ones, particularly for acetylcholine receptor positive autoimmune myasthenia gravis, is this formation of complement. And so what complement does is it essentially breaks down and starts kind of aggregating together. And then at the very end of this pathway forms this huge thing called a membrane attack complex. You can think of it like a little vortex or a little hole that kind of punches a hole almost into the membrane and causes damage on the muscle. And it's really this kind of process that can lead for many children, presumably to kind of fixed weakness, potentially fixed weakness of the eye muscles if they've had ocular myasthenia gravis for a long time, and are acetylcholine receptor positive, or some in older adults, we oftentimes may see some fixed weakness of the arms or the legs from chronic myasthenia gravis as well. And so there's really been a few treatments that have looked at what if we block this first part of this pathway, the first part of the complement inhibitor, can we improve patient symptoms, and can we decrease the amount of immunoglobulins that are in their bloodstream? And they have shown some promising results. The first two, eculizumab and ravulizumab, are intravenous therapies. And the third one that has been studied mostly in adults, but is now starting to be studied in kids, zilucoplan, I always say that wrong, but zilucoplan is actually a subcutaneous treatment. And so we'll talk about those. So one of the ones that has the most data so far for juvenile myasthenia gravis is a treatment that's called eculizumab. It is a treatment that has data from US sites and non-US sites. They had conducted a study really targeted at ages 6 to 17, although they initially just enrolled patients who were between ages 12 to 17, who had acetylcholine receptor positive generalized myasthenia gravis symptoms that were refractory to current treatments. And so for most studies, they look at a couple of different scales and response to treatment. And those two scales that are used in this one is something called the Myasthenia Gravis Activities of Daily Living Scale, and the quantitative myasthenia gravis scale, and these have been used across many different trials. And so this study used the medication, which is intravenous, and it's based on a patient's weight, given in a loading dose, and then it's given every 2 weeks. And for the purpose of this trial, they continued that for 26 weeks. This was what we call an open label study. So that means everyone who was enrolled got the treatment. No one got a sham or placebo treatment. And what they were able to see is that they showed some significant improvements in both of these scales. So 7 patients, or 70%, achieved a 5-point reduction in what we call the QMG scale. And 5 patients, or 50% of them, received a 3-point reduction in the MG-ADA scale. And so typically for trials, we'll say that if you have a greater than 2-point reduction in the MG-ADL, that's significant, that's a good change. And then for the QMG, if you have greater than 3-point change, that's a good change. So this actually met its what we call its endpoints, and it did really well. There were a very small subset of patients who experienced some serious side effects. 3 events in 1 patient of worsening of the myasthenia gravis, 1 patient who did have myasthenic crisis, and then 1 serious event of what's called a peritonsillar, right around the tonsils, abscess that was thought to be related to this treatment. And 1 patient had fever as well. There were some mild and moderate side effects that were thought not to be related to eculizumab. Otherwise, it was well tolerated. And so some of the findings actually prompted the European Medicines Agency to approve this in Europe, and they actually approved it for ages 6 to 17. And there are some clinical trials ongoing, continuing to look at eculizumab, and my hope would be that this is actually a medication that is accepted by the Food and Drug Administration in the US for use in juvenile myasthenia gravis as well. One thing I should mention about this category of complement inhibitors, especially in light of that peritonsillar abscess, is that mechanism of action, or the way that it blocks complement, is important for us in how we fight off certain infections. And so all patients require vaccine series to something called Neisseria meningitis, or a type of infection that can cause a severe infection of the fluid around our brain, meningitis. But in studies that they actually looked at for complement inhibitors, it doesn't seem like it really significantly reduces your response to prior vaccines, which is good news. And so some of the other medications that are being studied in this category, so one of them, like I said, is intravenous. This is ravulizumab. They're recruiting currently for pediatrics. We only have data so far for adults. There was recently 1 case report, so that's just a single patient who seemed to respond to ravulizumab when treatment failed with something called plasmapheresis, as well as steroids. And this patient in particular was very severely affected to the point where they needed a breathing tube. But per the case report, after 6 weeks of receiving ravulizumab, was fully without the breathing tube and actually back to full strength throughout their eyes as well as their arms and their legs. So seemed to have very favorable response. And we'll have to see how ongoing trials do in children as well. And then this is the subcutaneous complement inhibitor. This is a pediatric trial that will be recruiting patients from ages 12 to 18, and it's weight-based dosing as well. This has been studied in adults. This is a daily subcutaneous or right under the fat of your skin, kind of like insulin injections, treatment that they did for 12 weeks. They were able to show a favorable response, again, in that myasthenia activities of daily living scale. Many patients did report side effects, but most of those seemed to be related just to the injection site and reactions to the injection itself that were the most common. They are also doing something called an open label extension where they're continuing to follow those patients in the long term, and it seems to still be safe and well tolerated. And so we'll have to see if it works very well for children, and if it's also safe in that age group as well. And the last in this category of treatments is something called geferlimumab. This is a trial that has just started recruiting. It is also, again, a complement inhibitor, a C5 complement inhibitor. It is again, a subcutaneous, so right under the fat, but this is actually a weekly dosing, and it's also weight-based, but in pre-filled syringes. And so really this is still in the early stages. The only study that's been completed and has literature published so far is for a study that looked just at the safety and how the medication works in your body for adults. But now they are doing some ongoing trials in adults. And this trial for pediatrics is going to be the same. They're looking for safety. They're looking to see how the medication works in your blood and how it's distributed. Also with looking for some secondary endpoints we call of how well it works or how it improves a patient's MG-ADL scale and other scales as well. So we'll be looking forward to seeing what that shows. So we talked about the complement inhibitors, but there's another kind of mechanism with how myasthenia gravis continues to cause damage. And that's something that's called recycling of immunoglobulins. So we have all of these antibodies in our system that are blocking those receptors and causing damages to the receptors and for them to be internalized. And actually our body, for fighting off viruses, does something really smart. It takes these antibodies into the cell itself and actually has a way to recycle them. And so if you had the common cold, for example, and developed antibodies, this is a great way to develop more antibodies. It recycles them back out to the bloodstream to help fight off infections. But when we talk about autoimmune disease, that actually can lead to more damage. And so there was a discovery that if we can block this mechanism, or Fcrn, with medications, we can actually decrease the amount of circulating antibodies or immunoglobulins. And so there's 3 medications for pediatric myasthenia gravis that have been studied or will be currently under study in this category. And the first of those is efgartigimod. And then the second one that's most recent with some published data is nipocalimab. And then there's the last one there that has recently been studied, or rozanolixizumab. And then for these particular category of drugs, just to note, again, there may be a slight risk of infection, but it doesn't seem to really cause significant risk of infection. But because our immunoglobulins help us with formulating an immune response to live vaccines are contraindicated before and right after the treatment. You have to have some separation from the treatment in order to get a live vaccine. And so some recent highlights from this, there's no clinical trials that have been published, but there have been some research presented at scientific conferences. So one of the highlights from this is nipocalimab. So this is an intravenous medication that's given with a loading dose and then given every 2 weeks after that. There has been a study that has completed some information, some data for adolescents ages 12 to 18. Again, these are patients with generalized myasthenia gravis, not responding to current treatments. 5 patients completed their full study period of 24 weeks. And for those 5 patients, they actually were able to see that there was a significantly reduction in the amount of circulating immunoglobulins in their bloodstream, as well as improvements in their scales as well. And one of the things that was very exciting to see is that 4 of those 5 patients actually achieved very minimal symptoms, and so a very low score on how their myasthenia affects their activities of daily living. Per this particular abstract or poster presentation, there were no serious events reported. Another study that has been studied first in adults, and we have some data from, and is now enrolling for pediatrics ages 2 through 18, is Fcrn. So this is actually approved in the US and the European Union for acetylcholine receptor positive generalized myasthenia gravis. It's actually approved in Japan for all types of myasthenia gravis, not dependent on antibody status. This is also an intravenous medication, and interestingly, it's given once every 4 weeks. And then based on someone's clinical response to those first 4 weeks, then you can repeat doses, although you have to separate, in the US at least, you have to separate those sessions or those doses by at least 50 days between cycles. In adults, there have been obviously really good responses for the myasthenia gravis activities of daily living. And so among the 44 patients who were initially studied, at the onset of response, they started to see improvement by week 2 in 84% of the patients, and the duration lasted for greater than 12 weeks in about 34% of those patients. So it seems to be long-lasting, and maybe a second cycle may not be needed. And so this is one of the last trials we'll talk about today that's currently recruiting. And though this is a pediatric study that is again looking at ages 2 through 18, the study participants are going to receive a once-weekly subcutaneous infusion for this Fcrn inhibitor. So this is the first kind of subcutaneous infusion available as opposed to intravenous. And so this is now recruiting through different sites, US and then also outside of the US. It has, of course, been studied in adults. This is actually a study that has gone through what we call kind of phase 2 and going through phase 3 studies. And so they looked at this treatment compared to patients who received a sham or placebo. Although they didn't demonstrate what we call statistically significant change in their primary outcome, which was the quantity of myasthenia gravis scale, from the infusions up till day 29, they did show some improvements overall in the scales and good trends in those scales. The one thing about this subcutaneous infusion is that it's not just a quick injection. It does take 30 minutes to be infused throughout the abdominal wall. And then although, like we said, the primary endpoint was not statistically significant, it did seem to have potential benefit, and it was associated with reductions actually in the bloodstream of acetylcholine receptor antibodies, and was well tolerated without really significant side effects reported. And so when we think about all of these studies and all of these treatment approaches with juvenile myasthenia gravis, again, we kind of have to think about children as being unique. We have to think about those children who are presenting with symptoms before puberty versus those who are presenting after puberty. And we also have to understand some of the characteristics better. So for kind of looking at where I think the future of juvenile myasthenia gravis is going, there's a few things that are important to consider. One is we need to have a better understanding of the baseline characteristics of children who have myasthenia gravis. So we need to understand how their genetic typing, or their what we call HLA typing, is affecting their overall disease. We need to understand better in kids, do they have high levels of the circulating complement, and is that destructing the muscle membrane as a result of their myasthenia gravis? We also have very limited studies, like I was mentioning, just from different places in Europe and a couple places in the United States, and some studies out of Asia that look at how environment or ethnicity, and again, that kind of plays into genetics, impacts the patient's prognosis. And so we need to understand, are certain patients and populations at higher risk for going on to developing poorer outcomes, and essentially a decreased rate of spontaneous remission. And so really understanding these baseline risk factors for severe disease and those who go on to develop poor outcomes will help us to kind of navigate treatments and tailoring treatments to patients. We also have to do some further investigating into some unique features of pediatrics or juvenile myasthenia gravis. And so that is, the higher rate of children who present with ocular-only symptoms. Some of those children, of course, they're more likely to go into spontaneous remission than those who present with generalized myasthenia gravis. But some of them actually do go on to develop fixed eye weakness. I have a number of patients who unfortunately have had ocular myasthenia gravis for many years and have now really, because of that potential damage to the muscle itself from all of this inflammation and complement activation, have the inability to move their eyes, which it not only affects them clinically and their day-to-day function, but also aesthetically and overall for their overall confidence levels. So we need to kind of understand, again, going back to the risk factors for that, and how do we recognize who those children are early and maybe be a little bit more aggressive with their therapy as opposed to just using acetylcholinesterase inhibitors like pyridostigmine. We also need to understand why children, there's more likely to be seronegative patients in pediatrics. Is that because we have a different antibody that we have not identified, or is a different composition of their immune profile? And it would be wonderful to understand more about those kids who do go into spontaneous remission and what were the reasons why, and can we kind of modify some of their features to help those children who don't go into spontaneous remission. And lastly, we're going into the treatment. Of course, like I highlighted, there's now 6 to 7 trials that are looking at these complement inhibitors or Fcrn inhibitors for the treatment of adolescents or even younger for juvenile myasthenia gravis. So we need to know when we should use these, what stage of the disease, right, and who for. Right now, most of these in adults are used for patients who are refractory to what we call first-line and second-line immunotherapies. And so one of the immunotherapies that I didn't highlight here because we don't commonly use it in pediatrics, one of these second immunotherapies is called azathioprine or Cellcept, which essentially causes damage to our DNA and RNA, and that's how it works to decrease the immune response. But we can't really take that approach in kids. Those drugs can, essentially cause bone marrow suppression. There may be a slightly increased risk of malignancy. And I know in my own personal experience, when you talk about that with a family of a young child, that's not a risk that we're willing to take. So we need to be able to understand how and when to implement these therapies and how is it safe for them and what's the right dose. Another thing that's been really exciting in the adult world of myasthenia gravis is now a dedicated T-cell mediated therapy without having to use chemotherapy that seems to show some very favorable response for adults with very refractory myasthenia gravis. Again, that's a very significant procedure. We're still learning more about how that works in adults and how safe it may be, but is that something that we can use potentially in a young adult or an adolescent? And what's the lowest age that would be tolerated and for what reason? How severe would a patient have to be and how many treatments would they have to have tried and failed until we get to that point? And so really what I would love to see is our field going to a point where we are identifying early these children based on their immune profile and their genetics, and maybe their ethnic or environmental risk factors, and how we can really modulate their treatment to give them the best outcomes possible. And so I want to spend some time for the last 5 minutes before we go to questions about clinical trials in general. This is an area that is very complicated and difficult for physicians to understand, difficult for people and even in science to understand. And so I want to kind of guide you through how you can find these clinical trials and what are the questions you should be asking if you're interested. It can be a great opportunity for many children and their families, but it also can be sometimes a burden or scary because it is a lot of unknowns. And so there's 2 great ways for juvenile myasthenia gravis that you can find clinical trials. The first is the MGFA. So they have a wonderful website. And so if you go to myasthenia.org, On the top bar, there's a tab that says MG Research. And then right under that, you can click on pediatric patients. And so they keep up to date with all of the pediatric trials that are ongoing. So they'll have, like you see there, kind of the title and the summary of the objective of that particular clinical trial and who may be eligible. And then they'll give a link to the pharmaceutical company that's conducting this trial, as well as the clinical trials site. And so the second way that you can stay abreast of these opportunities is by looking at the clinicaltrials.gov website itself. And so if you go to clinicaltrials.gov, you essentially can, on the first page, put in myasthenia gravis, and then that'll come up with all of the treatment trials that have been completed or recruiting for myasthenia gravis of all ages. And then on the left-hand side, there's a really nice place where you can just put in some filters. So you can put in filters for actively recruiting, and then you can put in for participant age of child, age 0 to 17, and it will come up with all the studies. So as you can see here, that I did this search this morning just to double check. Right now, there's 18 total studies that are being conducted in juvenile myasthenia gravis. And again, that's a mix of trials that are actually looking at treatments or interventions, and also those trials that are looking, again, to understand juvenile myasthenia gravis and better from what we call its natural history. And so those are ways to find clinical trials. You can also ask your provider about any clinical trials they may know about, either at their site or other sites from their colleagues. And then, of course, there's some really important questions that you should think about when you're looking into a clinical trial. You can always, of course, ask your primary neurologist these questions about a clinical trial that you found or that they have brought up for you. But these are really questions when you meet with a clinical trial team and their representative that you can think of to ask. And so I kind of put it into certain buckets for giving us some guidance on things that may be important to you and your family. And so one is you just want to be knowledgeable and understanding what the study is about. So what is the purpose of the clinical trial? Am I going to get a treatment? Is it to try to figure out if that treatment is safe and how that treatment works in my body or my child's body? Or is this treatment to say that it actually is better than a different treatment? Is there a possibility that myself, or my child, in this case, would get a placebo or a sham as a part of the trial or as the entirety of the trial? So would I potentially get exposed to just a placebo treatment? What are the potential benefits from the trial? Will this potentially lead to improvement in my child's clinical symptoms? Will it potentially just contribute to our overall understanding of myasthenia gravis and helping my child and others down the line? And then you want to know who is sponsoring or overseeing the trial. So who is going to be responsible for the data and how much information are they going to see for my family? Will they see just my child's age and their clinical history, or will they also have access to their name and their date of birth? And so those are things that you want to understand getting into a trial. And that brings us into the safety and risks. So what are the potential risks and benefits? Those risks can be, again, what is my personal information that's shared, all the way up to what are the side effects of the drug that are known and what are the unknown potential side effects that we're investigating. And then what are the benefits? We talked about that already. You want to know what side effects are possible, those ones that have been reported before, and then kind of with this group of medications, if it's an interventional trial. And how will my child's safety be monitored? That's both, clinically when you're just talking to a doctor or a clinical trial investigator, but also with blood work or procedures. So how often will labs have to be drawn? How often will my child potentially have to do a procedure or a test? What are the supports in place to make sure that they're not experiencing any significant stress or discomfort or pain with those particular tests involved? Procedures in the participation, we kind of talked about that just now. You want to know, how does this compare to standard treatments? So will my child be able to continue on their current treatment? Will they have to stop it for a period of time? If they get worse during the clinical trial, how are you going to intervene? What are the treatments that you're going to give? Can they go back on their treatment? And can we withdraw from the trial at any time? The answer is usually yes. And then you want to know, how long will the treatment trial last? And what is your responsibility as a parent or as a family? How far do you have to travel? How many visits does that include? Do you have to do any scales online or in person? And do you have to report to the primary investigator anytime there's a potential concern for a fever or a headache or a side effect. And then you want to understand what is the potential compensation or cost. Again, we never strive to have this be the primary goal of a treatment trial, because we're looking really overall at a treatment and how it may help a patient and patients down the road. But this is a very impactful thing for many families. And so you'll have to understand, are you responsible for your transportation costs or for parking at the particular facility? Will I be reimbursed for those things? If I have an unexpected stay at the hospital, is that completely covered by the clinical trial, or is that billed to my insurance? So these are the kind of questions that you want to kind of understand getting into it. So although it can seem overwhelming, there are wonderful things about participating in a clinical trial: access to newer therapies, understanding, the disease process, potentially having benefit on controlling symptoms, and sometimes, of course, continuing on that treatment after the trial. So it is a great opportunity if it's something that you and your family wish to participate in, but you don't have to, may be available to you. And there may be many sites kind of throughout the US or local to you. And it's something that you can think about and investigate. And I hope that some of these treatments will prove effective for our juvenile myasthenia gravis patients as we go forward. And we have a more tailored approach to helping children sooner, so they don't have to suffer some of the long-term side effects from this rare disease. So with that, I'll end and I'll open it up to any questions. And I really appreciate your time. And this morning, I've listed my references, but that is a very boring slide. So I'll stop there.
Thank you, Dr. Wright. We do have a couple of questions. This first one is, with so many treatment options available, how do you determine the best approach for a child with MG?
Yeah, that is a great question and a really difficult one to answer, and maybe very different from each physician that you talk to. My own personal experience, particularly with generalized myasthenia gravis in children, is that the first 6 months can be very tumultuous. And I try to sit down and tell my families, we're going to go on a little bit of a roller coaster ride here. We're going to have to figure out the best treatment that works for your child. So my own approach for these treatments that are currently available, and then I'll talk about the new treatment trials. So for those that are currently available, is to try to figure out the treatment that may be the most targeted for their disease, again, based on what we know about their antibody status or their presentation. 2, the one that has the least side effects, and 3, the one that has the least burden on the family. And then I'll implement that therapy first, and then go from there. We'll follow very closely, usually every 2 to 4 weeks for the first few months of their disease. And if we see that they're not having improvement or having any side effects, we can kind of quickly jump to a different treatment, one that may have more side effects in the short term, or may have a little bit more of a burden on the family for time coming to the hospital, but that can hopefully get the disease under control. So that's my own personal approach, particularly for generalized myasthenia gravis in the first few months of the disease. For the newer treatments, really what we know is that these complement inhibitors and Fcrn inhibitors are very good for acetylcholine receptor positive, based on the way that we know that that antibody affects the acetylcholine receptors as well as the muscle-mediated damage. We're still learning more about those patients who have no antibodies or seronegative. And so really what this will come down to is understanding a patient's immune profile, so their levels of complement, their antibody status, and also it will depend on the side effects and what you want to do in combination and what your insurance company will allow you to try. So I would see that for many of these treatments, when they are approved in children, it will likely be for children in the same way that it was studied, for children who have generalized symptoms of myasthenia gravis, who then also are refractory to current treatments, whatever that may be, that you have tried and failed. But I'm hopeful that as we start to learn more about these medications and see that they may be very safe, that we can then apply them earlier in a patient's treatment course.
Thank you. This next question is, can anyone outside the US participate in clinical trials?
So yes, actually, one of the very nice things about the clinical trials in the myasthenia gravis space is that they are many sites outside of the US. So if you look at clinicaltrials.gov, many of these interventional trials actually do have sites outside of the US. And so that may be an option. And that's very different from some of the other disease spaces where a lot of the clinical trials are focused in the United States. There are treatment trials that are going on, for example, when I looked through in Italy, in Poland, in Asia. So there may be sites that are closer.
Thank you. This next question is, what are the biggest challenges in managing juvenile MG, and how can parents best support their children through treatment?
Yeah. So in my mind, from working with families and children with myasthenia gravis, the challenges can vary based on age, but one of the biggest challenges that I have experienced is for children who are slightly older, who are school-aged or young adults. And really the first, 6 months to a year of their disease, where they may have significant symptoms or what we call relapsing remitting symptoms that kind of pop up, but get better for a little bit and then get worse. It can really take a toll on your mental health and your social interactions with your friends and going to school and keeping up with schoolwork. So we really try to think about that when we talk about treatments. Like I said, what works best for a child and their family. And for the way that you can support them, so I'll give a shameless plug for the MGFA. There's a really great resource now for adolescents. They have a wonderful adolescent group they have for many time, and also for parents and caregivers. I often will talk to parents about some of these challenges, but I will be very forthcoming in saying, although I can be so empathetic and tell you my clinical experience, I've never lived through this as a mom or a dad. And so talking to other family members about how to support their child is really the best way to get some support and some care for your child. And also just, giving them the time and the space to take a step back from activities, not push themselves, to get their rest, because that's so important for myasthenia gravis. And just trying to let them know that, although it may be a troublesome time, you're going to get through it. And you as a family is going to do everything that you can to get them better.
Thank you. That's really great advice. This next question is for clarification purposes. Is it only children that are AChR positive are offered a thymectomy?
Yes, that is a good clarification. It has not been shown necessarily to be helpful in children who have ocular-only symptoms. So we consider the thymectomy in children who have acetylcholine receptor positive generalized myasthenia gravis.
Okay. And then this next question is juvenile myasthenia gravis generally milder over the person's lifetime than GMG acquired as an adult?
Yes, so it really depends on the age of onset. So prepubertal children do have a much milder course, and they have a much higher rate of spontaneous remission. And they also have a much higher rate of just having ocular-only symptoms. Once we get to the postpubertal range, many of those young adults that I follow can have a very similar course to adults, where they may have relapsing remitting disease kind of throughout their lifetime. Or mild symptoms kind of continuously. And so it's very important for us to kind of understand those two age groups and comprehend what are the treatment approaches that we can implement sooner to help prevent some of those long-term symptoms and complications.
Thank you. Well, that's all the time we have for today. Dr. Wright, thank you so much for joining us today and for your wonderful informative session.
Thank you. Thank you for having me.
And I hope everybody has a great rest of their day and good weekend. Take care.
Take care.